and we're just coming up now to 5 o'clock. So assuming everyone can see my slide on the screen, I'd like to welcome everybody all over the world, whether it's good morning, good afternoon or good evening, to this evening's webinar. We're joined by our speakers who will give a presentation, hopefully for within the hour period. There will be some questions at the end, and there's a way that you can interact with our speakers and that you can record or you can type in your questions within a chat function, which our GoToWebinar facility has on the right-hand side of the screen. I'd like to welcome this evening Professor Lanz, Otto Lanz, who is from the Department of Animal Clinical Services, Virginia Tech. Also, Dr. Nate Miller from Colorado Canine Orthopedics, and Dr. Stephen Brasina, our very own Chief Technology Officer from KYON, and myself. Brief introduction: my name is Ken Beasley-Evans. I've now been with the business for 12 months, and I am head of sales for a large proportion of the globe. I'm pleased to meet and see everybody this evening, and hope the course goes swimmingly with technology. Without further ado, I'd like to hand over to our speakers to begin our course this evening, which is the 5th in the series of webinars, and I'd like to welcome you all to our TPLO webinar this evening. Thank you.
Okay, well, hopefully this does work out. I'm actually doing this remotely as well, since my talk is not working on my computer, but they have a copy of it. So today, what I was going to talk about is just a preoperative planning for TPLOs. And this is, again, for just a routine case. This isn't going to involve dogs with excessive TPAs or dogs that have angular limb deformities. I'll briefly mention it, but this is just, again, for the basic planning of a TPLO. The main reason to do planning and to make sure that your planning is done ahead of time is that your preoperative planning and what actually happens, the execution of the procedure intraoperatively, should equal your postoperative radiographs and then your postoperative evaluations. In this way, it's not a big surprise when you go in and you pre-plan something and you come out. So what you plan going in should closely resemble what is coming out within, a few millimeters or so. The planning is very straightforward. The one thing that you will need is a lateral radiograph of the tibia, and you do want to make sure that it is a lateral radiograph. Does it have to be exactly 90-90? No, it doesn't. There's a study showing that it doesn't, but it is optimal to try to get a good lateral of the radiograph to make sure that your measurements and your anatomical points are going to be correct. You do want to include the stifle in its entirety and also the talus as well, and a caudal cranial of the tibia. Now, the caudal cranial of the tibia is mainly used to measure the proximal, medial, and lateral tibial angles, which we're not going to go over today, but this is important when you are doing a corrective osteotomy for a torsional or an angular limb deformity. But for the cases we're going to go over today, this is just a routine TPLO. The good thing too is that for the pre-planning, the tibia, if it's not, or if it is in cranial jaw, it does not matter. So in a TTA, it does matter, but for a TPLO, it is of no concern if the tibia is in cranial translation. Okay, if you can advance, please. As far as planning software, I mainly use VPOP. That's a very easy program to use. You can use JPEGs or DICOMs. Any image is very easily used. Biometric also has a program, Lightbox, which we are going to start currently using. They just don't have our templates available yet. And then Horus is also another available program that can be used. One thing to be very cognizant of is when you are taking radiographs is to make sure that you have a calibration ball. It can be of any size. You just need to know the diameter of it. The ones that we use is 1 inch or 2.54 centimeters. And you want to make sure that the calibration ball is centered as close to the stifle or the area of interest that you are looking at, because if not, it's going to influence the amount of magnification and calibration. Okay, next slide, please. The first thing after you take your radiograph is that we're going to determine the mechanical axis of the lateral tibia. And the mechanical axis is simply defined as the center point of the joint above and below the bone that you're interested in. So for the tibia, the center is going to be the talus distally going right through the intercondyloid eminence. And this diagram here on the top right shows the magenta dot just over the intercondyloid eminence. And when you look at the proximal distal view, you can see where the dot is, and that's where the mechanical axis is of the tibia. Now, sometimes this does become difficult, especially caudally to the eminence, and the reason for that is osteophytosis. So again, sometimes it does become difficult, but on a good lateral radiograph, you should be able to see the intercondyloid eminence pretty easily. Okay, next slide, please. So this is just showing a radiograph, again, center of the talus distally going through the center of the intercondyloid eminence, and just a close-up of where the intercondyloid eminence is, and then distally where the talus is. So making sure that you have these points is actually going to be the start of identifying or measuring the tibial plateau angle itself. Next slide, please. So we are going to define the cranial and the caudal points of the proximal tibial plateau. So the cranial point is the insertion of the cranial cruciate ligament, and then caudally is the insertion of the caudal cruciate ligament. The caudal cruciate ligament, again, with osteophytes, can be a difficult point to identify. One thing that you can look for is the proximal portion or the head of the fibula. The caudal cruciate ligament inserts just proximal to that, so that's a good reference point. So once you have the mechanical axis drawn, and this green line is going to represent the cranial and the caudal points of the proximal tibia, the next thing that you're going to do is just draw a line perpendicular to the mechanical axis of the tibia, intersecting the line that's being drawn through the cranial and caudal cruciate insertion points. And that angle, as you see here on the radiograph, is actually going to give you the tibial plateau angle. Once you have this angle, you can look on the chart, depending on your blade size, to determine how much you're going to rotate the proximal tibia. Okay, next slide, please. The blade size selection, and this is work that was done from Mark Glide, which is very helpful, is based on 25% of the length or the width of the proximal tibia. So that's going to be a point from the tibial tuberosity to the very caudal portion of the medial tibial condyle, which is again just above the fibular head. And we're going to take 25% of that distance, which you can see on the second radiograph. And what that represents is the minimal amount of tibial tuberosity that you can leave before you start encountering tibial tuberosity fractures. This is still a problem today. It really shouldn't be, because with good measuring and templating, you should be able to prevent the majority of tibial tuberosity fractures, which was a big problem with tibial plateau leveling osteotomies initially, but now with a lot of programs and planning, it's decreased in its occurrence. The osteotomy, if this is the blade that you can see here, and this white dot represents the center of the blade, the center of the osteotomy is going to be centered over the intercondyloid eminence. And that's going to help us determine what blade size that we're going to use. Next slide, please. And if you can just start the video on this. And this is just a screen capture from VPOP. And what we're going to do is we're first going to determine the length of the proximal tibia. We're going to take 25% of that. And what that is going to represent is what's known as D1, which is distance 1. And that's going to represent the very cranial portion of our osteotomy, and when we go with the blade selection. So again, this helps us determine how much proximally we can make our cut, and then we're going to take our proposed blade, and again, the center of it is going to be right at the intercondyloid eminence, the same as a mechanical axis, And then we're just going to increase the blade size. And here we're going to go from 18 all the way to 24 just to show you. And once you get to 24, you're going to notice that we're just shy of D1, but 27 makes it longer or encroaches on the distance, which will increase the chances of tibial tuberosity fracture. So we're going to stop at that point. The next thing that we're going to do is determine our second point, which is D2. And if you can advance the slide, please. Okay. Again, as a quick review, remember the center is going to be over the intercondyloid eminence, so that's going to be D1. And then D2 is going to be the distance just distal to the intercondyloid eminence, straight down to the medial cortex of the tibia. If you can hit play. And then we're going to go through plate selection. So again, we're going to go ahead and measure what our D2 is. And D2 is usually the distance is a little bit less than the radius of the blade you're going to use, because D2 is not at the center of the osteotomy, which is the intercondyloid eminence. So in this case, it would be 21.2. And then we're going to go ahead and plan our osteotomy. We know how much to rotate the osteotomy because we have already looked at the TPA, figured out the TPA, and we know how much to rotate it depending on the blade side, which is available in the chart. Okay, so we've gone ahead and rotated to the proper amount, and then what we're going to do is go through the plate selection. I like what I use as a landmark for how big of a plate is so that the distal hole on the plate fits just inside the intermedullary canal, and it is not any wider than the bone itself. Now, is there an exact body weight per plate size? That's hard to determine because some dogs are obese, some dogs aren't obese. But again, this is just a way to look distally at this plate hole that you can see distally. And again, that should just fit inside. The other thing that's important to note is that all the proximal holes on this plate fit within the tibial plateau itself so that we're not encroaching on the osteotomy, which can be problematic as well. If you can advance to the next slide, please. So this is just, again, drawings of what happens if you're off with your center of osteotomy. The first picture is a proper centering. And with the proper centering, you can see how the plate easily fits within the proposed osteotomy. You're not going to have any problems. And the amount of rotation that you do, let's just say it's 10 millimeters, is going to correctly rotate the tibial plateau. The second slide is if it's too distal. And if it's too distal, D1 is not going to be 25% the length of the tibial plateau or the proximal tibia, which is going to increase the incidence of tibial tuberosity fracture. And not only that, since the center of rotation is distal, you're actually going to have to rotate the tibial plateau more than what you measured because it's not over the center of the osteotomy. Now, the last slide or the last picture is if you're too proximal. Yes, you're going to leave yourself plenty of tibial tuberosity, but you're going to have difficulty putting the plate on the tibial tuber or the tibial plateau. And usually either the cranial screw or the caudal screw is going to encroach on the osteotomy line itself. The other problem with this is if you make a very proximal osteotomy, you have to rotate it less. And in this case, what you can actually do is overcorrect for the tibial plateau angle, because when you make a proximal osteotomy, you have to rotate the tibial plateau less. Okay, next slide, please. So again, intraoperatively, what we do is we place a 22 gauge needle, and this is a collateral ligament, which you can see on the image of the right, with the needle going through it. And on the image on the left, that's just a drawing showing where that needle is. And you want that needle to be, again, just below the meniscus, which is this light blue, and just above the tibial plateau itself. And you want to take time to find that so that we can draw a line distally, and that's going to give us D2. And then again, D1 is going to be from the tibial tuberosity caudally, which is 25% the length of the tibial or the proximal tibia. Next slide, please. After I have D1 and D2 marked out, this is just a drawing. This is an intra-op picture. I go ahead and put the plate on just to make sure that D1 and D2 are aligned properly, so that I'm not having or incorrectly put the needle, or I incorrectly measure D1, because you do want the plate to fit on there pretty easily. You don't need to overcrowd the osteotomy sites, because we want to keep these two distal screws and the proximal segment outside the osteotomy. Next slide, please. So post-operative evaluation, after I do a TPLO, I do go back, and these are just a small checklist of what I look for. I do recheck the tibial plateau angle like we did before, just to make sure that it is between 5 and 6 degrees. I know that's debatable, but that's in the literature. Worsey's paper, 5 to 6 seems to work quite well. I check the center of the osteotomy, the tibial tuberosity width, or D1. The osteotomy itself, there should be no gap, and it should be perpendicular on the cranial caudal view, which you can see on the far right. The location of the fixation pin, again, should be just proximal to the insertion of the patellar ligament. And I do use the jig and recommend using the jig. I check the location of the jig pins, and I make sure the distal one is centered and is monocortical, not bicortical. And then again, I check the implants to make sure the screws are properly seated, and I also make sure that they're not encroaching on the osteotomy itself. Next slide, please. This is just to remind you, you can see the cranial tibial artery. This is a lateral picture of a cadaver. You can see the osteotomy, you can see the fibula. You want to make sure that you don't angle the osteotomy, because if you angle the osteotomy, that increases the chances of, as well, of you hitting the cranial tibial artery, which is, again, just adds to another complication. Next slide, please. Again, proper planning, even for toy breeds, we're asked this a lot. If you just do those same rules for toy breed dogs, the tibial tuberosity does look a little bit odd when you're doing small breed dogs, and this is a small 3.4 kilogram Yorkie with a 4 millimeter plate, which is the smallest. It will work. You just have to be careful with planning. Be careful that you measure, as they say, measure twice, cut once, but it will work on toy breeds and in cats as well. We've done TPLO in cats. So this planning does work no matter what size of the dog. The rules are going to be the same. Next slide, please. So again, what's the consequences of bad planning on this first one? This is one that was actually rotated incorrectly. So instead of the tibial plateau being rotated caudally, it was rotated cranially. So this went from like 26 degrees to 40 degrees. This is one where you had an incorrect blade size. So the center of the osteotomy is distally, and it's too big of a blade as well. So again, we have fractured the tibial tuberosity. The same with incorrect D1 on the third one, where you just have encroaching on D1. It was measured incorrectly. And then this last slide, I just put this too numerous complications to count. This is what you definitely want to avoid. So again, preoperative planning is going to help you quite a bit so that you can minimize the amount of complications and actually increase the success rate. Next slide, please. And that's all. So thank you, and sorry for the little bit of technical problems, but if you have any questions or anything, I'm sure we can go over them after Nate gives his presentation.
Perfect. Thanks very much, Otto. Talking there about preoperative planning in TPLO. I'd now like to hand over to Stephen to talk about the advantages now with TPLO, and in particular the KYON TPLO system. So Steve.
Good. So there are a lot of TPLO plates out there. Why should somebody choose the TPLO plate from KYON? Well, we like to think it's because it's one of the better plates, and there are reasons why we've made the plate the way that we've made it. And so you look at the ALPS TPLO, called ALPS because it's based on our plate system, which is a plate system that we've had out for 10 years now. It's it's a good fit, it's less invasive, and you have improved healing. They're anatomically shaped plates, and they come in sizes from size 4 all the way to size 12. Now, KYON calls the plate that based on the width of the plate and not based on the size of the screw that's used with it. So if you want to think about like a Synthus 3.5 plate, well, that's kind of comparable to our size 10 6-hole plate. So one advantage there with our size 10 6-hole plate is that we actually have, so size 4 to size 12. So the size 12 plate can be used for really big dogs, and like Otto just showed, the 4 could be used down to as small as a 2.4 kilo Yorkie. Designed to be less invasive, so the distal tip of the plate allows you, with its rounded shape, to be able to slide it in underneath soft tissues, and Nate will show you that in his presentation to follow. But it's also good that you can easily find the holes in the plate to seat your drill sleeve in there if you're doing the percutaneous screw insertion, drilling through just a stab incision. It's easy to find and easy to use that kind of as a handle as well to manipulate the position of the plate. And our plates, this titanium alloy, is a very strong material. It's very biocompatible, and it's 22% stronger than a competitive plate. And that was a study here that I'll show you some pictures of in a minute. So anatomically shaped plate. So it's important that you see that you have on the proximal part, we have fixed screw direction. Now, some people say, well, I don't like fixed screws, I want variable angle screws. But actually, believe us, variable angle screws can end up getting you in trouble. With these fixed angle screws, because of the distal oriented direction of the most proximal screw, you will not end up risking going into the joint. If you have variable angle screws, you may think you're safe, you want to get close to the joint, but you can penetrate the joint, and this prevents you from doing that. The monocortical screws, we recommend using monocortical screws on the shaft section of the plate, and you can see monocortical screws allow you to not damage the interarticular or the blood supply in the interarticular space. Sorry, the intermedullary space. ALPS technology also has this minimal contact. It's based on what was called the PC fix in the early days when we were at the AO. And that point contact allows you to not disturb the periosteal blood supply, which is good for healing and good for keeping infection rates low. There's that taper junction of the drill sleeve tip that allows you to do the percutaneous drilling easier. You have locking or compression fixation with the distal hole. So with that most distal hole, you can drill a hole in that smaller part of the hole. You can see here this smaller section, and then as you tighten the screw down into that, you'll be able to do compression of your osteotomy. And then that rounded edge allows it to be slid under soft tissues easier. Again, anatomically shaped, well, this is also important if you want to look at how the plate sits on the bone after you've done the rotation and you put your plate on there. You know, we see that the plate stays very centered. This curved shape prevents you from ending up having your most proximal screw sitting too caudal. You can see some of these examples here where that proximal screw is sitting off the back edge of the bone. And it also reduces the risk of your most distal screw sitting very cranial. So you have also here examples of some other systems with straight plates where that distal screw is basically sitting on the front edge of the tibia, which you don't like to see. Accelerated healing. So this is the ALPS technology. You see that the underside of the plate has only contact at a few points there on each side of the screw hole. You have a point of contact that allows you to not disturb the periosteal blood supply. The screws that are used with the TPLO system are what we call KLS. So this is the KYON locking screws. And this screw system is used across a wide range of plates that we offer. Our DPO, our ALPS 2 system, acetabular fracture plates, arthrodesis plates. So we have a lot of plates that are based on this system. So if you have the ALPS and are using it with something else, well, then you can easily add a TPLO plate to the system. Or if you're using our TPLO plates and you need a trauma plate, well, then it's easy. You've already got the screws covering your TPLO system, so you could expand into a plating system. So here's the study that was performed. This was done by Seth Bleakley. It's currently, publication is pending, taking and performing a TPLO procedure with the KYON ALPS plate versus a Synthis plate, loading these with axial force in the test machine and seeing how much load it will take till it fails. And you see here, there's the limb pair, you know, left versus right, KYON versus Synthis, alternating the sides. You see what the ratio is here. The ratio goes from as high as 1.4 times higher, 1.67 times higher, to, in one case, it was actually less with the KYON plate, but the average was 1.22 times higher for the KYON fixed system than with the Synthis system. So it does allow a stronger fixation. Maybe the way the locking screws are, or the curved shape of the plate being more anatomical, whatever the combination of the features is, it allows it to be stronger. Here's again looking at the accelerated healing point, and this was done with years of research at the AO Center in Davos, where the point contact really does preserve your periosteal blood supply, which is crucial for quicker bone healing and reduction of infection. Again, these are titanium alloy plates as well as titanium alloy screws, so you get really good, strong material that's very biocompatible. And this is the size range all the way from the size 4, which, you know, it's a 4 millimeter wide across the plate. That uses, here you see KLS diameter 1.5, so it's a 1.5 millimeter diameter locking screw, all the way up to size 12 with 8 holes, and that uses a 4.5 millimeter diameter locking screw. There is a table that gives kind of a guideline for the weight of the patient for the different plate sizes. Again, this is just kind of a general guide. You're gonna know more precisely when you do the planning, as Dr. Lance showed. But you can see here the different sizes of plates, the different screws that are needed with them. It's a good overview of what the system covers. Here's the other systems that are used with these screws. So if you had, for example, a 4 millimeter diameter screw that uses a T15 head recess, a 3 millimeter diameter drill, it's used with the ALPS 2 size 10 and 11. It's used with your TPLO size 10. It's used with the DPO plate. So there's a wide range of other systems that use these screws. And that's the end of kind of the summary of the TPLO system and its compatibility across the other items that are offered by KYON. And if you have any questions, please type them into the question field there, and I will look through those and prepare those for Dr. Lance and Dr. Miller. Thank you for your attention.
Thanks so much, Stephen. So far this evening, as Nate just gets your slides together there for the final part of our talk this evening, we've gone through preoperative planning. We've had an overview there from Stephen on KYON TPLO system, and now over to Nate, specifically to talk about minimally invasive techniques in TPLO to minimize morbidity. So Nate, you have the final session. Thank you.
Thanks, I appreciate it, Ken. My name is Nate Miller. I'm a surgeon in the United States out in Colorado at a all orthopedic practice, and I appreciate the opportunity to talk to you today. I'm going to talk about some of the minimally invasive techniques which can be used to minimize morbidity, accelerate recovery during TPLO. Otto talked about the mechanics of things, but it's important to realize that we're operating within, it's easy to look at the x-rays and feel that the bones are without soft tissues, it would be easier if they were, but certainly healing, infections, recovery are all heavily related to the soft tissues. So whatever we can do to minimize problems there is beneficial. In terms of a general overview of the tools that we have in TPLO to minimize the invasiveness of the procedure, I've just listed a few. It may not be a fully inclusive list, but here are some of the things that we use in our practice to help to minimize invasiveness of TPLO. Arthroscopy, I think, is beneficial. We can make smaller incisions, that type of thing, and so that helps. Certainly, I think most surgeons these days will avoid muscle elevation and packing. Personally, I think that gauze packing, and there's evidence in the literature to support this. We get a lot of debris that's left, and maybe related to infection rates that we saw in the early days of TPLO being higher. Locking low contact plates like the KYON system, I think, are highly beneficial in terms of minimizing the morbidity to the blood supply. And certainly the monocortical screws in the KYON system, I think, are beneficial as well. What I'm mostly going to focus on today is tendon sparing, so minimizing our impact on the tendons in the area of the TPLO so that we can have those tendons be as strong as possible post-operatively. Obviously, the advantages of minimizing the trauma are decreased infection rates, both due to the decreased debris as well as reducing vascular trauma to the bone, both from our surgical intervention as well as the plate itself. I personally, adopting these tendon sparing techniques, have seen a significant reduction in the number of post-operative seromas that I see. I would say that it's often said that that's just a kind of nuisance complication, but I think for a lot of seromas in the days of severing the tendons, basically those seromas represented failure of that repair, and there are some significant consequences to that in my mind. We can improve the dynamic stability of the joint post-operatively by maintaining the strength of these tendons as best as possible, and can accelerate the return to function for the patient, which helps to build muscle mass, especially in a situation where we're relying on dynamic stability with the geometry modifying procedure. It's important that muscle mass return rapidly. For a little bit of anatomy here, the term PES or PES, and I can never say it right, anserinus, is a human term. Essentially, in humans, these tendons are conjoined, come together as the goose foot, and attach on a single location. The anatomy in the dogs is a little bit different, and it's important to understand the anatomy when you're trying to preserve these tendons. They're distinct tendons that attach to 3 areas on the tibia. They're close to each other, but they are distinct. And the 3 tendons are the semitendinosus, the gracilis, and the caudal belly of the sartorius. This is just a picture illustrating these tendons, and essentially just to help orient. Basically, this is distal down here, proximal up here, and the cranial aspect of the dog is up here. Essentially, this is the semitendinosus tendon. I have split the fascia here. They are closely associated with the fascia, so it's not easy to do. Semitendinosus tendon, gracilis tendon, and then you can see the caudal belly of the sartorius here. The tendons are distinct. They are not just incorporated entirely into the fascia. And here's a cross section of that, so you can see this large area of tendon as opposed to the fascia in this area. If you simply close the fascia, you're not doing justice to the tendon. PES tendon closure, the traditional exposure here is to cut these tendons, and really they're, in the traditional kind of description of the technique, there is no standardized closure. Slatter says routine closure in layers. That's the extent of it, and Boger-Ab routine closure is performed. I think that addressing these tendons and helping them is important. Their importance in stabilization, all three of these muscles do provide a caudal force on the tibia. And since we're relying on dynamic stability here, any type of failure of a tendon repair will result in loss of this force. And even if there's gap formation at the tendon repair site, you're going to see an increase in the effective length of the muscle tendon, and this would reduce the effectiveness of the caudal force that we rely on for stability post-operatively in TPLO. We did do a study that was at the same time of the study that Steve was referring to. We basically looked at the load to failure of various suture sizes and patterns in the pes tendons if they're severed. There was a demonstrable difference in the suture size and pattern, but the important thing out of this kind of work was the fact that the forces that are counteracted, or excuse me, it's not totally clear what the forces that need to be addressed by the repairs are, but they are likely very high. And even the best repairs really didn't even come close to approaching the normal physiologic loads on these tendons. So the best approach here is to simply not cut them, and that is entirely possible, fairly easy technique. I know a lot of surgeons do this. I'm going to describe my personal approach. I think there's some variations on this that people would have, and so you know, I don't proclaim for this to be the right way to do it, but I think it provides you with a starting point and a blueprint. I make an incision, and again, we've got proximal up here, distal down here, and then this is the tibial tuberosity over here. So this is the dog's left leg laying on the table. I make an incision in the fascia just below the semitendinosus tendon. You can see on these tendons here, that tendon is illustrated. That's the gracilis. We've got the semitendinosus right here. I make an incision right here and use a AO periosteal elevator to separate between the tendons and the underlying periosteum all the way up here to the belly of the sartorius. Once I've done that, I will then make an incision essentially at the insertion of the caudal belly of the sartorius. Personally, I like to reflect this out of the way so that I've got adequate visualization in my area where I'm going to perform the osteotomy and rotation and that type of thing. But really, the gracilis and the semitendinosus are below that area, so you don't need to sever those tendons. This is after that's been done. So this is the caudal belly of the sartorius right here. There is some fairly tendinous tissue right in this area that does provide good suture when eventually we close that area. But this provides good access to the collateral ligament, so you can see all of the anatomy you need, and the top of the joint is right in this area. Again, these tendons and fascia have been left alone. I will say that there's somewhat less exposure than with the traditional approach, and initially this is a little bit uncomfortable in terms of placing your plate and your osteotomy, but with good post-operative planning like Otto's described, you can absolutely, you know, make the osteotomy just like you want it, and with a little bit of time, not much, you'll become very comfortable with an approach like this. Once the plate once the osteotomy has been performed, and I use a jig as well, and the segment rotated, you can then slip this plate underneath the gracilis and semitendinosus tendons and place it proximally. I will say that it is important. Your visualization is somewhat impaired in this area, and so I would say be careful not to slip off the caudal cortex with the plate. Make sure that your screws aren't engaging, you know, the caudal cortex, or I should say damaging the caudal cortex, and that this is medially. I do this by just palpating. You can fairly easily palpate the bone in this area and make sure that the plate is centered there. I think that it's critical in a technique like this to be using a locking plate. You don't require the perfect contouring that was necessary with non-locking plates. And given the lack of visualization in this area, I think that's very helpful. Once a plate has been placed, I'll secure it personally with screw number 4. The guide is very helpful in acting as a handle on the plate in terms of moving it to the appropriate position, making sure you're happy with your contact in the various feet of this plate at the proximal segment of the osteotomy. One thing that is helpful in all these techniques, once you got the plate placed and you're trying to place these more distal screws, personally, I just reflect the tendons proximally or distally to allow access there. You can make a stab incision. If you do, it would be preferable not to make that through the tendon. And flexion of the stifle will relax the tension on these tendons and allow you to move them more freely. Proximal screws are placed. Obviously quite simple, and you've got easy access in this area. Closure, I just make, I use a locking pattern in that tendinous tissue of the caudal belly of the sartorius, and that provides pretty good security there. Once I've done that, various cruciate sutures in the areas of fascial incisions, finish the closure of the fascia. I find this closure actually quite easy. I think it honestly saves me time now that I'm accustomed to it rather than a full approach. In general, I use AUT PDS for a 50 to 100 pound dog, but obviously the size of the suture will be dictated by the size of the patient. And really, when it comes to size of the patient, I would say to you that really with any size dog, this is a very feasible technique. Even the smallest of dogs, obviously small dog TPLOs are a pain and they're much more difficult. And at first I would say develop these techniques in larger dogs, but once you get comfortable with it, you'll do it in all patients. And that's the end.
Perfect. Dr. Miller, thanks so much for your presentation there, and thanks also to Stephen from KYON internally, and also from Prof Miller as well, Prof Lance as well. We now have some questions that have been in the chat. They've been recorded, so thank you again for those. Stephen and guys on the panel, you have some questions, I understand.
Yeah, so there is a question here, I guess, to both of the surgical speakers, having to do with the position of the proximal pin for the jig, and if the shape of the plate, interferes with that, if it, what their experience is with using plates around the proximal pin.
Yeah, it is. You become accustomed to putting that pin in a position that works well. Personally, I try and have that pin above the insertion of the patellar tendon just to avoid a stress riser. I don't know that that's critical, but I always feel like that helps. And then I've found that if I angle that fairly perpendicular to the long axis of the tibia, that helps me avoid, obviously those are fixed angle screws, and so if you hit your pin, you got to work around that. I basically angle it fairly perpendicular. That allows me to miss the distal 2 screw holes, not the most distal, but the distal of the proximal 3. And once I've got 2 in, then I remove my pin, and that allows me to get the 3rd in fairly easily. If for some reason you hit the pin, a very nice technique is just to put a monocortical screw in temporarily and just sit it there as a placeholder. Once you've got 2 screws in, you can pull that pin in, out, put in your 3rd screw, and then pull out the monocortical screw and make it bicortical. So I find that, if you do hit your pin, you can avoid problems that way.
Just to clarify one thing, and I don't know if you if the person asking the question means the anti-rotational pin or the proximal jig pin. If they're referring to the proximal jig pin, what I usually do is go about 5 millimeters below where I put the needle in to start my D2 measurement, and I push it underneath the collateral from caudal to cranial and then lift it and put it in. And if you look at the KYON plate, it does have almost a small curve proximally, but why I put that pin there is I don't like the most proximal screw to be, I don't like the plate to be more proximal than the proximal jig pin, if that makes sense. So about 5 millimeters below it. And I really haven't had any problems with that pin interfering with placement of the plate if I measured correctly. Now, every once in a while when you do, one suggestion is after you put in the anti-rotational pin, you may have to take the proximal jig pin off to do that. And sometimes though, that'll be caused by just incorrectly or underestimating D1 of some sort. So I try to put the proximal jig pin the same place 5 millimeters below where I put the needle in to look for the joint.
And I'm the same.
Great.
And
then Nate, there's a question more directed to you, having to do if you experience any difficulties in rotating the osteotomized segment using your less invasive approach.
No, not at all. I don't find that it affects it in any way. I mean, if there's difficulties rotating, it's usually, well, you know, sometimes it's like the large German Shepherd or Great Dane that has a huge fibula and a really ankylosed fibula-tibia joint. Those are the ones that are problematic for me. Or if you've made a poor cut, you know, that will alter rotation. But I don't think that this technique will make it any harder to rotate at all.
Nate, we've seen Otto's picture there of a 2.4 kilo Yorkie that has been done with the size 4 plate. Are you also using the smallest plate on the toy breeds?
We don't have the smallest plates yet. I mean, we do teeny little dogs. We use, I mean, honestly, it's just a matter of logistics in terms of we haven't gotten them yet. So, but yes, very small dogs. I think it works very well. I mean, obviously, from a technical standpoint, we joke because we charge more for a 110-pound dog, and honestly, a 2.5 kilogram Yorkie is much harder and more difficult, and we should charge more for those. So, but those dogs do wonderful. I love TPLOs and small breed dogs.
Great. There are no other questions here coming in from the attendees. Anybody have anything to ask? Let's look at the chat. There's nothing in the question section.
You know, I got
Nothing
one
in chat
thing,
either.
and also I asked Otto if he does similar, but I've found it very helpful in terms of contouring using the KYON plate. I find I almost never have to contour it. One of the keys is dogs with a lot of medial buttress. I will make a little kind of circular, just in front of the cranial, or excuse me, the collateral ligament. I'll make a little cut in that large amount of buttress so that the plate foot will sit down against the bone, which I think is beneficial from a mechanical standpoint, as well as the fact that that pretty much avoids me almost ever having to contour plate. And if you don't contour the plate, as Steve said, you're really safe in terms of not putting a screw in the joint. So,
yeah, those 3 feet on the underside of the proximal part of the plate allow you to, with just a little bit of repositioning, sliding the plate around, a little rotating, you almost always find a good place where it sits stable with those 3 feet on the medial aspect there.
do you resect that buttress commonly, Otto, or not?
yeah, usually larger dogs with a lot of buttress, I just take a 15 blade and cut just a small square and it fits in there. To be honest, I don't think I've contoured the TPLO plate. I tried it in the lab one time and it is difficult to contour one. I will tell you that. It's not the easiest thing to do.
Nate, there's one more One more question here, Nate. It's with your less invasive technique, have you ever had any issues with popliteal bleeding?
No more different than regular. You know, I didn't feel like I had an increase in popliteal bleeding associated with changing, and it's probably been, honestly, I think I've been doing this exclusively for 6 years or something like that. You know, it was around the time that we did that study that I kind of started to do it. So no, I don't think it changes that in any way.
I think it has to do, the bleeding sometimes can happen with the angle of your cut. If you look at the caudal cranial view and you look where the cranial tibial artery is, if this is neutral, meaning perpendicular to the long axis, if the osteotomy is like this, usually you will hit the cranial tibial artery. So and this is a little bit advanced and off topic, but that distal jig pin is a really good guide to keep your blade parallel to that pin so that you will make a perpendicular cut. And if you're scared, aim distally, because it's probably going to turn out perfectly perpendicular and you're going to miss the artery. So not quite in the scope of this, but you know, training residents, you'll see that when a resident calls you over really quick, it's usually because they've hit the cranial tibial, and it's because when you look at the post-op, their osteotomies are angled in a proximal direction.
Yeah, and I use I'd say 50% of why I use the jig is because I have that distal pin to allow, you know, for a visual, you know, concept of just that angle that Otto's describing. And, you know, the tendon sparing technique, at first you're a little uncomfortable with your exposure for the osteotomy because it's just it's not the same picture that you're used to. I would encourage you as you start to really stick to those specific planning techniques that Otto described to help you replicate the appropriate osteotomy that you planned.
And I don't know, this is a good question that came up that I just saw, and I personally do not use the compression hole. I did a few times, but really, if you do a good cut and you rotate it, I don't compress routinely. I did it just to do it once or twice, but I would say I do not compress anymore. I just use locking screws. And I don't know if you want to comment on that, Nate, if you use the compression screws or not.
I do not use the compression screws. I am the same as you. There's you know, the way I rotate, I get a little bit of compression as I'm doing that, you know, not from the plate, but just, I do think the osteotomy should be good, but I've always been nervous. I would rather rely on locking screws, and yeah, I don't compress.
Right. And one other question to clarify that somebody asked, which is another good question, is the monocortical screw in the proximal segment, that's just temporary. The proximal screws are always bicortical, the distal ones are monocortical, and that is if the anti-rotational pin, which no matter how perfect you plan for it, I'd say every once in a while the drill bit hits it, I stop and maybe put in a 14, just something to hold it, the rotation in place, take out that pin, finish the rest of the screws, and then replace that monocortical.
Yes, that's exactly what I do. And I always like to have 2 screws in before I pull out the anti-rotational pin. And sometimes, most of the time, you can get 2 full ones in before you do that. But sometimes 2 of your screws are going to hit that pin, and then you just put in a monocortical temporarily and replace it.
If I had about another 2 hours, I'd go over into pivot shift because well, I'd need 2 hours and about a 6-pack of beer is what I would say I'd probably need for this. Slobodan and I have talked a lot about this, and I can just tell you certain factors that I believe contribute to pivot shift. Okay, and
I'm interested to hear.
Okay, so this is just commonalities. I'm not saying this is what causes it, because unfortunately this is being recorded and I cannot confirm or deny anything I've said. So the first thing is it's usually a dog that has a medial meniscal injury and you do a large medial meniscal meniscectomy of the caudal horn. The second thing is not using a jig. that seems to be not 100%, but that's just something they have in common. And the other is that if you go back and carefully measure these dogs, they tend to be slightly over rotated when you really look at them carefully. And when you look at the other is shifting of the proximal segment. When you look at how concave the medial tibial condyle is compared to the lateral tibial condyle, the lateral tibial condyle is very, I mean, it's round. It's like half of this, whereas the medial is more subtle in its how convex it is. I'm sorry. And the same with the femoral condyles. And so doing the medial meniscus and slightly over rotating, it'll make the femur cranially luxate, not so much the tibia caudally. Now, how you correct those, that's another huge discussion, but I would say the removing a large portion of the caudal medial meniscus it happens. People have put extracapsular sutures, they've redone TPLOs, they've done opening wedge osteotomies of the proximal tibia. It's difficult, but I would say, knock on wood, with good pre-planning, and I do the approach the same way Nate has, I really haven't had problems, because the other issue is it failure of the pes when you do the suturing of the pes insurinus? Does it actually fail, and then you have overcompensation by the biceps? So a lot of theories, but not 100%.
Good. Well, there are no further questions here from our attendees, and I think we're right on time with being able to wrap this up. Ken, I'll put it back to you.
Absolutely. Thanks very much. And again, thanks to all the speakers this evening, to Otto, to Nate, and to Stephen for taking the time. Thanks to the internet as well for supporting us in this and for not dying and leaving us talking to ourselves. And I wish everybody a good afternoon and good evening. And thank you for your attendance. Good night.
Bye-bye.
Bye-bye.
Guys.
Thank you.